Hi friends, Dr. Pepe speaking. Welcome to webinar number 5. We will speak today about the lateral chest radiograph. Let's go to the first case. Case 1 is a PA radiograph, which belongs to an 86-year-old woman with chest pain. And I'm offering you 4 possible diagnoses. I imagine you see the diagnosis there, the abnormality there in the middle of the left lung. And the answer is, where is the lesion located? Is it in the lung, pleura, chest wall, or if you're not sure, you can tell me to show you a lateral view. Okay, stop the presentation now, look at the film in your home, make up your mind, and then come back when you are ready. Well, now we are back in the presentation. To me, to be honest, I will take the answer number 2. I'm sorry, number 1, I made a mistake. Number 1 is the answer because in the countdown view, the density, the opacity is ill-defined and it looks pulmonary to me. But the sensible answer really is show me a lateral, because a lateral view may clarify many findings in the PHS radiograph. So I'm going to show you a lateral, and there you see that the ill-defined lesion in the PA view now is very well defined, and it is located in the lateral chest wall and has a typical pregnancy sign, placing it in the chest wall, and it is extrapulmonary, definitely. So see how the lateral chest radiograph improves considerably the diagnosis in this case. And the lesion was examined with a CT. There we see an extrapulmonary lesion. See how the intercostal vessel is pushed up away from the chest wall. So that means it's completely extrapulmonary on the chest. And the needle biopsy demonstrates a lymphoma of the chest wall. Why I'm showing you this case? Just to prove that you need a lateral chest film sometimes to interpret faint lesions that are indeterminate in the PH chest radiograph. Let me show you a second case. This is a PH chest radiograph of a 61-year-old man with hemoptysis. And I'm going to give you 3 options. You don't have to stop the presentation. Just which one will you get? Call the chest normal, which appears to be, take a lateral view, or do a CT. Well, the sensible answer will be to do a CT because it's an easy answer. But the important answer is that you have to take a lateral view because you may get some information. And information definitely you get because when you have a PA chest film that is absolutely normal, at least to me, you see here a significant size nodule, irregular, which has a high probability of being malignant. And still you have a second observation that is in the hilum. The hilar shadow has the typical donut sign that I have mentioned before. There is a donut, and there is a hole in the center of the left upper lobe bronchus. And if you have a donut, you can be almost certain that the patient has lymph nodes in the mediastinum. Now, lateral view has discovered a nodule in the lung and lymph node in the mediastinum, so the diagnosis now is inescapable. The patient has probably a carcinoma of the lung with metastasis. I'm showing this case to emphasize that in the PHS film, about 26.4 of the lung is hidden by the mediastinum, the hilar, and the diaphragm, in this area, more or less, in pink. So if you take only a PHS view and you don't take a lateral, you are going to miss a little over the 25% of possibilities of seeing a pathology, seeing abnormalities in the lung fields. And this is important. That is a very important role of the lateral chest radiograph. Well, this patient was examined with the CT, of course. Doesn't tell us anything new because it shows the lymph nodes in the subcarinal area, which we already knew, and the mass in the lung, which we also have seen in the lateral view. PET-CT shows a marked uptake in both areas, and of course, the final diagnosis was a carcinoma with metastasis to subcarinal area. So what is the main role of the lateral chest radiograph? Well, the first one is to clarify indeterminate lesions in the PA chest, as we saw in the first case. And the second one, and more important, is to detect lesions not visible in the PA radiograph. As I mentioned, about a little bit over 25% of the lung is not visible in the PA. So therefore, we need a lateral chest radiograph to complete the diagnosis. We are going to see some examples now, but before, we had to study the basic anatomy of the lateral chest. My guess is that about 50% of the radiologists and 100% of the other medical profession don't want or don't know how to look at the lateral chest X-ray because they reject it somehow. But this is very easy if you know where to look. You know some basic anatomy. Here there are two lateral chest radiographs of two different persons. One is slimmer, the other one has a different body habitus, but we still see the same thing. First, we see the skeletal structures. We see the sternum anterior in both of them, and the dorsal spine behind. You see that very well. And those are areas that are not seen in the PA view, so we see them only in the lateral. We see also the trachea in the middle, which is very easily seen in the PA, but it's also very well seen in the lateral in almost 100% of the chest films. And you see under the trachea, you see the hilar region that we talked about in the previous webinar. As you remember, the normal anatomy, anterior to the trachea is the right hilum or the right pulmonary artery. Posterior to the trachea is the left hilum of the left pulmonary artery. What else do we see? Well, we see beautifully the shadow of the heart, smaller in this case and a little bit larger in this one, but still normal. We see the diaphragm, both of them, both hemidiaphragm, and we can identify them. Remember that the right one is the one that goes all the way to the front, and the left one is the one that stops when it reaches to the heart shadow because of the silhouette sign. So all of this is visible in the lateral chest radiograph, is easily identifiable, and will help us to get our bearings in interpreting the lateral chest. To study the lateral chest radiograph, once we have seen the basic anatomy, we do the same thing that we did with the PA. In the PA, we divided the chest radiograph, the PH radiograph, into three areas: superior, middle, and inferior. In the lateral chest radiograph, we do it differently. We divide the chest into three areas: anterior, middle, and posterior. And we use very easy landmarks to draw the line. We use to delimitate the anterior part, the anterior wall of the trachea, and then the posterior wall of the heart. And this is the anterior area. To delimitate the posterior area, we trace a line going across the anterior aspect of the vertebrae. And this is the posterior area. And of course, the one that is in the middle is called the middle area. This is basic. Today we are going to start about the anterior area of the lateral chest. Let's go to case number 2. This is a 38-year-old man with pain in the right hemithorax. I'm giving you a PA and lateral views. And the question is, how many abnormalities do you see? You see 1, do you see 2, do you see 3? And then the easy way out, which is show me a CT, but I will advise you not to answer that, because you have to experiment and see how many abnormalities do you see in your home. Okay, stop the presentation, and then we will go back when you are ready. Now we are back, and let's see how many abnormalities do we see. Well, I see this one. This is AC1 in the PA view, and it has a nodule there, the patient, that I'm not sure whether it's intra or extrapulmonary. Tell you the truth, I had to do a CT to be sure. And then on the lateral view, I don't know if you saw anything, but considering that we are talking about the anterior area, the anterior zone, then we look at this area, which is black. It is called the anterior clear space. You see it better in the cone down view. And what will we see? The anterior clear space is called like that because it's uniformly the black. And here there is a density, opacity, is defined, rounded. You see it over there too, over there also. And this is abnormal. So the correct answer is 2. We see 2 abnormalities. 1 in the lateral chest wall and 1 in the anterior clear space. We had to do, of course, a CT to prove it. And there in the CT, you see the lateral chest wall lesion, which happens to be extrapulmonary. It's a chest wall lesion. And then the second one, that is the anterior mediastinum, that was seen perfectly well on the lateral view and not visible in the PA. I made an excellent diagnosis in this case. The only problem is that it was wrong, because I knew that thymomas, this is more likely thymoma. I knew thymomas metastasize along the pleural lines. So I thought it was a malignant thymoma with the metastasis in the pleural region on the lateral chest wall. This is a lateral view. There you see how this thing matches what we saw in the lateral chest view. The patient was operated on. Unfortunately for him, it was a benign thymoma and an unrelated neurofibroma, which led us to the diagnosis of the thymoma. Okay, let's see the anterior clear space. Let's talk about the normal anatomy of the anterior clear space. The anterior clear space is more or less this area here, which is limited anteriorly by the chest wall and sternum, and posteriorly by the mediastinum. And it has a significant amount of lung inside. And any abnormality, either from the chest wall, the mediastinum, of the lung, will be invisible in the PHS film because it will be occulted, it will be hidden by the shadow of the mediastinum and the sternum. However, when we take a lateral view, we have an unimpeded view of this area on the lateral view. And that this is an excellent window to see abnormalities of this zone in the lateral view. If we take a sagittal CT, we see the limits. There we have the sternum as an anterior limit, the aorta and the pulmonary artery as a posterior limit, and they see an excellent window there to see any abnormality in this area. The same thing we can see a little bit less well defined, of course, in the lateral chest film. Sternum, aorta, pulmonary artery, and anterior chest wall. In this case, is very small, but it can be much bigger depending on the body habitus. Let's see a few examples. This is a partial PHS film in a 43-year-old woman that was operated of a breast carcinoma some time ago, and this is a routine control. And we don't see, or at least I didn't see, any abnormality in this patient. However, if we take a lateral view, I'm sure you at home will be seeing the abnormality readily because it has a rounded lesion, more like elongated lesion there behind the behind the sternum, and it has an appearance of being extrapulmonary. But the important thing is that we have to do a CT to investigate it. And the CT is clearly extrapulmonary, has a pregnancy sign, is opposed there to the rib. And my first diagnosis in this particular case were lymph nodes from the carcinoma of the breast, metastasis from the breast carcinoma. Fortunately, this lady was operated on, and it happened to be a fibrous tumor of pleura. So she was lucky, and I made a mistake. But still, the important point is not whether I was right or not, but that the abnormality was readily seen in the lateral view in the anterior clear space. Another example, 57-year-old woman with myasthenia gravis. Chest wall, chest X-ray called normal, apparently normal. Lateral view, you see a large mass there in the anterior clear space. No question about it, no mistake. You cannot be wrong. And that's the importance, again, of the lateral chest view and the anterior clear space. Now, in retrospect, when we look at the AP view or the PA view, we see what I mentioned previously. There is a double contour of the aortic knob. And that indicates that there is a mass in front of behind. But this finding was overlooked in the initial examination, and it was discovered when the lateral view was done. CT, of course, demonstrates a large mass in the anterior mediastinum over there, who happens to be a thymoma. Another case, 72-year-old man with moderate dyspnea. There it is, nothing special about the chest X-ray, elongated aorta, changes in the spine, nothing special, nothing in the lungs, practically normal chest X-ray for a 72-year-old man. However, what we see in the lateral view, a nodule, very clearly seen in the anterior clear space superimposed over the aorta. Has to be studied. It was studied with the CT, of course. A sagittal view of the CT confirms the nodule. We has indeterminate appearance, but unfortunately, it happens to be a carcinoma of the lung. Thus, again, to emphasize and to stress the importance of the lateral view, demonstrating lesions not visible in the PHS film, and especially in this area in the anterior clear space. Two pitfalls. One is technical, and this is very important, is when the technician don't tell the patient to elevate their arms enough. And then you have a very bizarre shadow here in the anterior clear space. It is corrected if you tell the technicians to take the picture, to take the chest X-ray with the arms elevated, and then it is after the same patient, after elevation of the arm, all this shadow over here and this funny rounded shadow has disappeared, and we see a large anterior clear space with no problems at all. This is important. Remember, remind your technicians that don't do that. Don't always elevate the arms. Second, elongated aorta. As we get older, 50, 60 and more, then the aorta elongates as normal. But what happens? There is ascending aorta usually unravels and then covers the anterior clear space. Much more difficult to see anything there. So be careful evaluating the anterior clear space in any patient over 50 or 60, because it's going to be more difficult and you can make mistakes there. So be careful. To summarize, remember that the anterior clear space is an excellent window to see lesions that have been occurred in the PA. The lesions may be extrapulmonary opacities, maybe mediastinal masses, or maybe pulmonary diseases. Depending on the clinical history of the importance of the finding, you will have to do ACT to demonstrate and to confirm the abnormality. Let's go now to case number 3. This is a patient that has been operated for colon carcinoma 5 years ago and has been controlled with the CT of the chest, which had been read as normal. And this is the first control radiograph after 5 years of treatment. And the patient was obviously asymptomatic. I'll ask you 4 questions. How many abnormalities do you see? 1, 2, 3, or the easy way out, show me a CT. Please don't do that. Always study the PA and the lateral chest radiograph before doing the CT. Now stop the presentation, look at the films at home, take your time, and come back when you are ready. Okay, we are back, and obviously there is an abnormality there. There is a scar tissue from the intervention, and I have seen previously, but still is an abnormality. It's now abnormality number 1, and abnormality number 2 is in the lateral chest radiograph. And to tell you the truth, I discovered this case, and I was ready to call it normal until suddenly I saw something. I saw this small nodule there, and that was at the end of the examination. I almost missed it. You can see it much better in the countdown view, a nodule, which is too large to be a vessel. It's too far away from the hilum to be a blood vessel. So this is abnormal. So what you do? I didn't call it a metastasis, but I ordered a CT, of course. But yes, I was curious, and I checked the previous CTs. This CT from 2010, just after the operation. And if you look at it, and you know where to look, you see small nodule over there. In 2014, the nodule has enlarged. And in the recent one that I ordered, the nodule is even larger. And there was a single metastasis, solitary metastasis from carcinoma of the colon, who has been missed for 4 years, has been growing slowly, but has been missed for 4 years in the CT studies. So sometimes the lateral film can be useful, even more useful than a CT. Okay, that's an important observation. Again, another case. I'm showing this case, as I showed you the case before, because up to now, we have been talking about the anterior clear space. But the anterior clear space finish more or less. This one is a very large one, but it usually finish in the middle of the space. That's the anterior space, anterior clear space, lower part. Well, the lower part is occupied by the heart. And we had to look, when we look at the heart, we had to look at superimposed opacities over the heart, as we saw in the previous case with the nodule. In this particular case, this is a man with cough and fever, so the most likely diagnosis is pneumonia. Do you see the pneumonia in the PA film? No. Do you see it in the lateral film? Yes, because this patient has a pulmonary infiltrate with air bronchogram either in the right middle lobe or the lingula. Okay, those are the areas that are superimposed here and there, that are superimposed over the lung on the lateral view. And this is the most common abnormality that you are going to see in the lateral view over the cardiac shadow. Superimposed pulmonary disease, either nodules, bronchiectasis, or acute disease in the lingula or the right middle lobe. You see the patient 3 weeks later, the infiltrate over there has disappeared, confirming that there is only a right middle or lingular pneumonia. Okay. Sometimes this is unusual, but sometimes instead of superimposition of the right middle lobe or lingula over the heart, you are going to have an intrinsic disease of the heart. These are two lateral chest film in two different patients. One is a 21-year-old man, asymptomatic. The other one is a 69-year-old man with moderate dyspnea. The heart has a uniform density. So anything over the heart is either any shadow over the heart is either superimposed or it is inside the heart. Here we have a linear shadow. Here we have a more irregular shadow, sort of a pork comb calcification. But both of them are in similar location. This is a location of the aortic valve. So when you see this and that, in a young person is rare, but in an old person is not unusual, you have to think of calcification of the aortic valve. Remember that in the plain film, we use high kV technique that usually burns calcification. You don't see them very obviously. You see then like shadows that are not much different from the heart behind. Okay, so you can do, in this case, you can do a CT and you see the aorta coming down and the calcification. This is a patient with a congenital calcification, calcified aortic stenosis. The other patient also has calcification, the root of the aorta. The aorta comes here. It has not been included, this calcification. That also corresponds to aortic valve stenosis with calcification. The age of the patient is important because in the young person has to be operated on. In an older person, it may be sort of a aging change. Change is secondary to the age, and they may or may not be operated, has to be qualified by a cardiologist. That is something that you see inside the cardiac shadow occasionally. Another thing you see on the cardiac shadow, railroad tracks calcification, which are associated to coronary artery disease, as you see in this case, but this is very unusual. This is in our case. We don't see nowadays so many coronary calcification. When you see a railroad track nowadays, is usually a stent that has been placed. It's by far much more common. Artificial railroad secondary to a stent than the natural calcification secondary to coronary artery. And the last calcification you are going to see is this. It's a 58-year-old woman with previous cardiac surgery, heart slightly enlarged, the sternum post-operation, and all we see is a tiny calcification here, can be missed easily on the PA view, and on the lateral view, you see a obvious calcification there along the chest, posterior chest wall, which is amorphous here and correspond to pericardial calcification secondary to previous surgery. You remember in the old times, tuberculosis, tuberculous pericarditis was the most common cause of pericardial calcification. Nowadays, it's either secondary to surgery or secondary to viral pericarditis, something that you have to go to a clinical history to determine the importance. Okay. So far, we have talked about calcification, and let's talk for a minute about fat in the heart. This is a 53-year-old man with chest pain and apparent cardiomegaly in the PA view. It looks like an enlarged heart, nothing else. And on the lateral view, we are going to determine and we are going to find why is important fat in the heart. Normally, in the chest X-ray, you don't see fat. You cannot differentiate fat from water density, from soft tissue densities. But in the lateral view, in the heart, you can see the epicardial fat, which is this gray area, superimposed or in front of the myocardial density, which is more dense. And then you can see that, as I say, as a gray area, and then you see another gray area, which is the mediastinal fat. And in between, this is a myocardial fat, This is the pericardial fat, and in between you see a dense band which corresponds to the pericardium. Pericardium usually is a fine line. If it is thickened, as it is in this case, it indicates that there is fluid for whatever cause in the pericardium. So it is an excellent, when you see it, you don't see it very commonly, but when you see it, it's an excellent sign of pericardial effusion that, of course, has to be confirmed with echocardiography. Let's look at the case. This is a few days later. You see the fat, epicardial fat in front of the myocardium, mediastinal fat, and in the middle, this dense band which correspond to pericardial effusion. 3 months earlier, you can see a tiny effusion there. It not, of course, not as big as this one, as large as this one. So the fluid has been increasing, fat behind and fine in front. And then you have CT. We have a CT. You can see beautifully how the pericardium is thickened because of the accumulation of fluid. You see the heart, the myocardium finish here. This is the epicardial fat, the fat in top of the myocardium, and this is the mediastinal fat. This is an excellent sign, as I see, very accurate. If you see it, it's a very accurate sign for pericarditis, and that's what this patient had. Okay, and that's an important thing to look for in lateral views when you have an enlarged heart. Remember, in the cardiac area, always look for superimposed opacity. This is the most common thing that you are going to see. Look for central calcium, which is usually located in the aortic valve, railroad track calcification, usually in a stent, and the epicardial fat stripe sign. Did you see it? You can make a almost certain diagnosis of pericardial effusion. And now case number 4, a very short discussion about one subject. I'm not going to tell you which. This is a 22-year-old man with moderate dyspnea. This is a PHS, slight scoliosis, and I suggest 3 diagnoses: cardiomegaly, pleural effusion, and show me a lateral. And I hope by this time you will learn that the correct diagnosis or the correct procedure in every PHS film is show me a lateral, show me the money, okay? As Tom Cruise used to say, show me a lateral. Okay, look at it, wait, and tell me what will you do. Is it cardiomegaly, is it pleural effusion, or you want the lateral? We are back, and then you have a lateral. And what you see in lateral, a very obvious thing, a pectus excavatum, marked pectus excavatum, visible here in the axial CT. See how there is no room here for the heart, and the heart is displaced completely to the left side because it has no room there in the area between the sternum and this dorsal spine. So a diagnosis, a possible diagnosis of pericarditis, of myocarditis, or myocardial dilatation of the heart is easily put to rest because you see a marked pectus excavatum there. And I'm presenting this case because I want to talk about the sternum. This is the most common abnormality of the sternum that you see quite often, and most of the time you see it, most of the time you need a lateral to diagnose it. And the rest of the external diseases are very difficult to see, either in the PA you don't see the sternum at all, and on the lateral view, many times it's very difficult to see discrete lesions of the sternum. You can see the trauma, and you can see, as in this case, a marked decalage of the sternum. This is not trauma. This is, well, it's trauma, but it's surgical trauma. This is a patient with a bilateral pulmonary transplant that you will probably call normal chest X-ray in the plain film. Said when you look at the lateral, you see the telltale sign of the transverse sternotomy, which is a nice way to tell you that this patient has had a pulmonary transplant. This sign may be useful in the presence of bizarre appearances of the chest, that in this patient has a normal left chest, quietly abnormal, apparently bronchiectasis all over the right lung. And when you see the lateral, you see that it has a transverse sternotomy, and this patient, the bizarre appearance, is simply due to a unilateral left lung transplantation. And this is a useful tip, especially if you are taking a diploma examination, you can surprise your examiner. Just to finish, 72-year-old man with pain in the sternum. Normal in the chest film, no abnormalities. Then you have to take a CT. The CT, there is a lytic lesion in the body of the sternum. PET CT, high uptake in the area, and the patient was discovered to have a hepatocarcinoma, and this was a metastasis, which 6 months later has increased considerably. I'm showing this case just to establish 2 points. One, that the sternum is difficult to see in the lateral view. It's impossible to see in the PA, but on the lateral is difficult. So any anomalies, any problems that you have with the sternum, you have to do a CT to clarify your diagnosis. And second, the great majority of lesions of the sternum are malignant. So if you see a lesion in the sternum, just from the beginning, think that the patient has a malignant disease, either hematologic or metastatic disease. Okay? And then external lesion, the same thing, difficult to see in the plain films, better study with CT, and most of them are malignant. To summarize, and this is the last slide, checklist of the anterior area. We divide the anterior area more or less in 2 sides. The superior, which has the anterior clear space, and the inferior, which has the heart. In the superior, look for opacities in anterior clear space. As I say, it's an excellent window to see those abnormalities and then confirm them with the CT. In the inferior, in the heart, calcification, intracardiac, usually the aortic valve, peripheral, usually calcification in the pericardium. Look for epicardial fat pad in front of the heart, and you can make the diagnosis of pleural effusions. And especially, this is the most important thing, look for superimposed lung abnormalities in the anatomic areas of the lingula of right middle lobe. And finally, the sternum is a special area, always study it with CT, and remember that the majority of the lesions are malignant. That's all. Thank you very much for your attention, and I will be waiting for you with the next webinar in the 2nd or 3rd week of January. Thank you very much.